Welcome to Health Professional Radio. I'm your host, Neil Howard. Real glad that you could join us again. Going to be having a conversation with returning guest, Dr. Paul Limburg, a consultant at the Mayo Clinic and also CMO for screening at Exact Sciences. And he's joining us on the program, returning to talk about some new data concerning the CRC-AIM modeling and the importance of compliance when it comes to screening. Welcome to the program, Dr. Paul Limburg.
Thank you, Neil. It's always a pleasure to speak with you.
For our listeners who may not be familiar with you, give us a brief background. Tell us what it is that you do there at the Mayo, and also talk about your role at Exact Sciences.
Yeah, thanks, Neil. So I'm the Chief Medical Officer for screening at Exact Sciences and also a practicing gastroenterologist at Mayo Clinic. Over my 30-plus year career, I've been focused on cancer prevention, more specifically GI and colorectal cancer prevention.
Mm-hmm. Now, colorectal cancer is the second leading cause of cancer death. Is that correct?
That's right, Neil. When you combine the cancer incidence rates for both men and women, the colorectal cancer ranks as the second most common cancer. The interesting thing is that colorectal cancer is also thought to be one of the most preventable, if not the most preventable form of cancer.
Is that through early screening? Is that the main reason that it's most preventable?
That's right. We know that screening, early detection for colorectal cancer is effective. There are numerous studies that have shown that people who are regular participants with colorectal cancer screening are less likely to develop the disease and less likely to die from this disease. There are also multiple effective test options that have been endorsed by guideline groups. So it really boils down to awareness for patients and providers, and then choice to pick a screening strategy that works best for each individual.
So let's talk about some of the screening options. Now, we're familiar with colonoscopies. You know, they're invasive. Is that the go-to for screening, or are there many less invasive options out there?
That's a great question. So there are multiple different options, and groups like the U.S. Preventive Services Task Force, the American Cancer Society, others have endorsed equivalency in the available test options, at least the ones that pass a quality threshold and an effectiveness threshold. So there are invasive tests like colonoscopy or flexible sigmoidoscopy, another endoscopy test. There are radiologic tests like CT colonography that are included in some but not all guidelines. Then there are stool-based tests like fecal immunochemical testing, which looks for microscopic blood in the stool, and multi-target stool DNA testing, which has a component to look for blood, but also for abnormal DNA markers in the stool sample.
Talking about some new data from the concerning the CRC-AIM model, what is the CRC-AIM modeling? Yeah,
so I'll take a step back and just to give a little bit of context for why modeling in general. Many of the screening comparisons that are made are based on modeling data because, as you might expect, using clinical data or randomized controlled trials or other sorts of study designs to really look out, sometimes 10 years, even longer, is a big investment and is not practical in many instances. So there are established models that have been used to look at some of these colorectal cancer endpoints by varying the different types of tests, the performance of the tests, patient participation with the tests. And so what we did at Exact Sciences and with other collaborators is develop a model called Colorectal Cancer and Adenoma Incidence and Mortality, or CRC-AIM, to really try to provide a robust platform for interested investigators to look at all of the different components that go into projecting the effectiveness of colorectal cancer screening. And that's what our studies that we recently had submitted and accepted to the DDW meetings demonstrate. Some of the different analyses that we have built, again, with external collaborators using this CRC-AIM modeling platform.
Now, how does that relate to people getting tested effectively, especially during a time when it's not, well, I wouldn't say not advisable, but a lot of people are skeptical about going in to have any type of testing, whether invasive or not, at someone's facility?
Yeah, it's a great point, Neil. I think we all have to recognize that there are so many competing priorities now more than ever. Even prior to the current pandemic, colorectal cancer screening participation was suboptimal. There are an estimated 45 million individuals who would be eligible in the United States for colorectal cancer screening who are not up to date with that preventive service. So the modeling data allow us to really kind of analyze some key contributors, some key components of that whole screening equation, and many of those are relevant now to the current situations that we face with respect to patients not necessarily wanting to come into the office, limited access for some procedures based on closure of different clinical facilities, endoscopy units, for example. So the modeling analyses help to provide additional information and clarity to those screening decisions that patients and their providers need to continue discussing.
As far as that discussion goes, what would you recommend to those who are concerned?
Well, I think at this point, it's important to remember to what you called out earlier on that there's more than one option for colorectal cancer screening. Screening colonoscopy is one of several different possibilities. There are home-based tests, for example, multi-target stool DNA testing, or the commercial name is Cologuard, can be ordered from home, delivered to home, sample collected from home, shipping picked up at home. So the entire screening process, at least to get the initial result, can be done without having to leave someone's residence. If there's a positive result from either a Cologuard test or a FIT test, the other stool-based option that can also be done at home, then a follow-up colonoscopy would be needed, and that needs to be done in a qualified facility.
Now, does Cologuard have a much better sensitivity than some of the other tests that are out there, like you said, the FIT test?
Yeah, we look at a couple different components to whether or not a test is going to be effective. Performance, which includes sensitivity and specificity. Adherence, which is patient and provider willingness to complete the test. And then access, can the patient actually obtain the test based on their selection of which option they think is best for them. So with respect to the performance in the large pivotal trial that led to FDA and CMS approval of Cologuard for clinical use, Cologuard was shown to be more sensitive than FIT for cancers and precancerous lesions.
Where can our listeners get some more information about Cologuard?
There's great information at cologuardtest.com, and there's also a way to get both patient information and provider information at that website.
And does the Mayo Clinic have an option online as well where we can get more information about gastroenterology at the Mayo Clinic?
Absolutely. So mayoclinic.org is a site for health information on multiple different topics. And there's also a way to find out more about the organization through that website as well. And
as far as Exact Sciences goes?
I think Exact Sciences, there are several different places, digital resources that patients, providers can find. The most relevant to this conversation would be the cologuardtest.com.
Well, thanks for coming back, Dr. Limburg. It's always a pleasure, and I'm sure we'll talk again.
Appreciate your interest, Neil. Stay safe, and thanks to everybody for making sure that colorectal cancer screening stays part of the conversation.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Audio copies of this conversation are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, download it, SoundCloud, and be sure and subscribe to our YouTube channel at youtube.com, Health Professional Radio.